Welcome back to the deep dive. Today, we are walking what feels like a professional tightrope.
It really is.
It's that fundamental tension between our most sacred duty patient confidentiality and the absolute need to train the next generation of clinicians.
It's the ultimate balancing act, isn't it? We need real-world cases to teach, but patients place this immense trust in us.
Right.
So our mission in this deep dive is to synthesize the detailed GMC standards into a really crystal clear, high-yield framework. This isn't just theory. It's essential stuff for anyone learning or teaching, medical students, physician associates, you name it.
Absolutely. Think of this as your shortcut, really, to understanding the hierarchy of safety and disclosure. We want you to walk away from this knowing what the safest, most professionally justifiable action is every single time, whether that's for a training record or, an exam scenario. Okay, let's start with the one core truth that really frames every single decision in this area.
The core truth is that anonymized information is the professional default. It just is. Patient data is obviously crucial for the whole health system planning, research, all of that. But for any purpose other than direct patient care, the requirement is really clear. You must use anonymized data wherever possible.
Okay, so anonymization is always path number one. But what if we hit a wall? The case is complex and we feel we must disclose identifiable information for teaching. We are technically breaching confidentiality then, aren't we?
You are, and you need a solid legal basis to stand on to justify that breach.
So what are our options?
Well, you've got 3 legally permissible grounds. First is if it's required by law, like a court order. Pretty straightforward. The third one is statutory processes for big national data projects, which is extremely rare for individual teaching cases.
Which brings us to the second one, which I assume is the one we use most of the time in medical education.
Exactly. It's explicit consent.
Okay.
In the vast majority of these teaching scenarios, publishing a case, presenting at a conference, you have to secure explicit consent. And I really want to stress that word, explicit.
It's not just a nod on the corridor.
No, absolutely not. The doctor has to make sure the patient feels absolutely zero pressure. You have to be so clear that their clinical care has nothing to do with their decision.
Their care is completely independent of this choice.
Completely. If they say no, the answer is no. Full stop.
That's a key distinction. And that standard of no pressure is a massive professional hurdle. So let's move to where this gets a bit murky. The direct care divide. When can a trainee or a student access identifiable records without that specific explicit consent?
This all hinges on one question. Are they part of the direct care team?
Okay.
If a medical student or doctor in training is, rostered as part of the team providing care, they can access personal information based on implied consent.
Because most patients just get it, right? They understand that the team looking after them needs that info.
Yes, exactly. They accept that learning is part of the process.
So the minute a student is assigned to take a history or write notes on a ward round, they've crossed that line. They're an active member of the team.
Correct. But if that same student is just observing a consultant's lecture on a case they aren't involved in, or presenting a case from 6 months ago,
they're no longer part of that direct care team.
Exactly. And in those scenarios, they go right back to needing explicit consent, or the information has to be rigorously anonymized.
That makes the line very clear. Observer status needs permission or anonymization. Active team member relies on implied consent.
And there is that rare alternative.
Yeah.
If anonymizing or getting consent is genuinely not practicable for a quick teaching moment, you can disclose relevant info, but only if the patient's been informed of this possibility and their right to object.
That sounds like a high-risk exception, not the rule.
It is a very high-risk one.
Let's talk about the highest risk scenario of all, the one that always comes up in exams. The patient who lacks capacity to consent.
Yes.
Why are the GMC rules so much stricter here?
Well, it's because the patient simply can't speak for themselves, and they may never be able to. So we have this incredibly high duty of protection.
So what's the first step, the first question you have to ask yourself?
The first step is non-negotiable. Can you achieve the same educational goal using information about a different patient? If you can, you must. That's the least restrictive path.
That's the critical triage step. What if we think the patient is, say, acutely unwell, but they're likely to get capacity back?
Then you wait. It's that simple. If you can, you defer using the identifiable data and you ask for their consent later when they're well enough. If you can't wait.
Maybe for urgent case planning.
Right. Then you have to seek the views of legal proxies, welfare attorneys, guardians, or even close family to get a sense of what the patient's wishes might have been.
And what's the absolute red line here, the thing you must never, ever do?
You must not publish information that could identify a patient who lacks capacity. Publication is, it's final, it's irreversible.
So disclosure to trainees is only okay in the most extreme cases.
Only if it's absolutely necessary for their training, there's no practicable alternative, and you have no reason to believe it's against their best interests. It's an incredibly high bar.
Let's shift to the practical stuff, case studies, logbooks, e-portfolios. When we talk about anonymization for these, what does rigorous actually mean? Because just taking the name off feels, well, insufficient.
It is absolutely insufficient. The rule is that anonymization must be as complete as you can possibly make it. Just removing the name, age, or address is almost certainly not enough.
Why not?
Because of something called Jigsaw identification.
Jigsaw identification.
Yes. It's when different sort of harmless bits of information can be put together to reveal someone's identity.
Nice.
So you have to remove other identifiers' initials, the full postcode, NHS numbers, and critically key dates.
Dates, like date of diagnosis or admission.
Exactly. A single specific date could be cross-referenced with public records. And suddenly your educational activity becomes a serious data breach.
That advice on dates and postcodes is incredibly high yield. Now, what about an e-portfolio, where you might need some identifiable details for it to be properly audited?
That's a justified need, but the rules are a bit different. If the info is kept securely in a protected, audited training record, then potentially identifiable data can be used without explicit consent.
So it's a trade-off, security for functionality.
Exactly. But you still have to remove as many identifiers as you can and manage it all under strict data protection rules.
Now, contrast that with information that's going to be widely accessible, like a seminar or a published journal.
If it's widely accessible and identification is even remotely possible, explicit consent is mandatory. And it needs to be fully informed consent. You have to tell the patient the purpose, the exact info being disclosed, and who's going to see it. It's an ethical thing, not just paperwork.
Okay, a quick pause on non-medical observers. Like a secondary school student on work experience, they're not bound by the same professional oath.
This is a high-risk area. They require explicit consent from the patient just to observe. That's a higher bar than for a medical student on the direct care team.
And the doctor's responsible for them.
You are. You have to confirm the student understands confidentiality and make sure their presence isn't, stopping the patient from speaking, frankly. You're on the hook for their compliance.
Right, let's pivot. Let's get really SJT focused here. What is the single highest scoring stepwise framework a doctor should use in one of these disclosure scenarios?
Okay, let's call it the GMC confidentiality triage.
Perfect. Lay it out for us.
Step 1. Rigorous anonymization. Always try to remove all identifiers first. Names, dates, locations, the lot. If you can make the teaching point, you stop there.
And if you can't?
Step 2. Seek explicit consent. If you need identifiable data for non-direct care education, get explicit, unpressured consent. Detail what, why, and to whom.
Step 3.
Step 3. Check legal necessity and security. If you can't get consent, is the use strictly necessary for direct care or a secure, audited record like an e-portfolio? If yes, you maximize security and you minimize identifiers.
And what about that really rare scenario, the untraceable patient, maybe data from decades ago, where public interest might come into play?
That's the exceptional step 4. Seek external advice. If you can't get consent because the patient is untraceable, you must seek advice. And crucially, it has to be from someone not directly connected with what you want to do.
Like a Caldecott guardian or data protection officer?
Exactly. Their unbiased view is what justifies your decision professionally.
That external oversight is so important. Okay, let's talk traps. What are the common mistakes that catch people out in exams?
They're almost always about taking shortcuts. Trap number 1, assuming removing the name is enough, we know it has to be way more rigorous than that.
Right, dates, postcodes.
Trap 2, failing to respect a patient's refusal. A no means no, it's a hard stop. Trap 3, using a case from a patient lacking capacity when another case would have worked just as well. The existence of an alternative makes it unjustifiable.
What about the student confusion?
Trap number 4, disclosing identifiable information to observers like work experience students without explicit consent. That's a clear breach. They are not part of the clinical team's implied consent framework.
And the last one.
And finally, trap 5, ignoring a patient's right to object when you're trying to use that rare, not practicable exception during a busy ward round.
Let's do 3 quick-fire scenarios to really hammer these patterns home. A student wants to use a unique, easily identifiable case for a public seminar, and the patient consents.
You can proceed, but you have to be absolutely sure the consent is truly informed. The patient needs to understand the full breadth of the disclosure.
Okay. You're entering a case into your secure, audited e-portfolio, but total anonymization would make it useless for reflection.
You remove as many non-essential identifiers as you can, you make sure the record is maximally secure, and then you use the remaining identifiable data, justifying it as necessary for a training audit.
And finally, a college student is joining your clinic for work experience.
You must seek explicit consent from each patient to allow that student to observe, and you confirm the student understands their duty of confidentiality.
Okay, it's time for the 3 crisp takeaways for you to carry forward from this deep dive.
First, rigorous anonymization is the default, and that means scrubbing names and context dates, postcodes, to stop that jigsaw identification. Second, explicit consent is the rule for education. If the purpose is teaching, not direct care, identifiable data requires informed, unpressured, explicit consent.
And
third, protect those without capacity. Never, ever publish identifiable data for a patient who lacks capacity. Only disclose it to trainees if all alternatives are completely exhausted and it is strictly necessary.
And our final thought for you to explore. The guidance is clear that for very old data where a patient is untraceable, you still have to seek external advice from a Caldecott or data guardian. What does this tell you about the limits of public interest? It means that even the best intentions for teaching have to be validated by an unbiased third party. Ethical integrity always has to be the absolute priority. Mastering these standards protects your patient's privacy and your professional standing. Stay safe, stay informed, and we'll catch you on the next deep dive.